touch base about the HPA axis first. We all know that it all starts from the hypothalamus, wherein we have got the CRH, which basically is going to control the pituitary using its CRF or CRH receptor. This is a small peptide. All the hypothalamic peptides are small as compared to the other hormones, which then regulates the production of ACTH, which acts on the adrenal via the MC2 receptor to produce the effect of mainly the glucocorticoid, the cortisol, along with DHEAS. ACTH has a minor role in terms of production of aldosterone, and that is responsible for the lack of salt wasting which happens in somebody who has got a ACTH deficiency or ACTH resistance. So if you have somebody who comes to you with hyponatremia, predominantly in perspective of a cortisol deficiency, so you have low sodium and an inappropriately normal or low cortisol, how would you differentiate that this is a pituitary problem, this is a ACTH resistance, and this is a primary adrenal problem, Dr. Sandeep?
Primary adrenal problem, there will be a aldosterone also, so there will be hyperkalemia, sir.
And so you will have hyperkalemia and no clinical feature.
Pigmentation.
So pigmentation and hyperkalemia. Let's go to the second state, ACTH resistance.
ACTH will be hyperpigmentation, but there will be no hyperkalemia.
So you will not have hyperkalemia. And finally, in the perspective of somebody who comes to you with a pituitary problem or ACTH deficiency,
no hyperkalemia.
So no pigmentation, no hyperkalemia. So potassium and pigmentation will tell you how to classify the level of problem, whether it is primary ACTH resistance or ACTH deficiency in that perspective. Now, aldosterone, 90% of it is controlled by renin. So it's not that the ACTH has no role, but it is not that main driver as far as regulation is concerned. Now, another very, very important regulator of the ACTH synthesis in the whole process is the arginine vasopressin hormone. And we know that AVP is responsible for osmolar regulation. So it will do everything to bring down your osmolality. If your osmolality goes up, first thing AVP will do is to try to conserve your urine output. It will produce an antidiuretic effect. It will then have an effect on the vasopressin activity, which is going to cause the increase in blood pressure to bring back your volume status. If somebody is getting dehydrated, they will start working on that. And then it will also start your cortisol production through this process. So AVP also stimulates cortisol. And we discussed this, that this is very relevant in the treatment of congenital adrenal hyperplasia. So why is that individuals who are mineralocorticoid deficient in the setting of 21-hydroxylase deficiency require more glucocorticoid?
Because there is mineralocorticoid deficiency, the adrenal will not be there, but aldosterone will not be there. So there is a hypovolemic state. This hypovolemic state will cause much more increase in the AVP level.
So AVP regulation occurs at two levels. One is osmolar and then is volume. Now I'll talk about that later, but what is the gross difference in terms of osmolar regulation versus volume regulation?
It's much minutely controlled actually, but the minute change in the
So 1% change in osmolality will trigger AVP secretion, while volume change will be much dramatic, 10 to 15%. But the level of AVP elevation will be much, much higher if you have a volume problem. So that becomes important. So if you have hypovolemia, you will have more AVP. Then
that AVP will stimulate the ACTH.
More ACTH, more
Cortisol production will be needed, but there is no cortisol.
So you will have other pathways like aldosterone will become more, 17-OHP will more. So if you have inadequate mineralocorticoid supplementation, you would need more glucocorticoid to compensate. This is this AVP axis which is there in that perspective. Now, we know that all the adrenal hormones are not produced at the same level. The cortisol production is much higher, and this remains high around, you can say 8 to 10 milligram per meter per day is usually what is suspected to be the normal production. This is more from an adult perspective. DHEAS is not existent as far as the childhood is concerned, but after puberty, it's again a big production. But the aldosterone production is much lower. Now, this has implications in the setting of biosynthetic defect. So, which do you think is more likely to be affected in the setting of deficient production of steroids, glucocorticoid, or mineralocorticoid? Why?
Because they are in large volume, so even small reduction will be.
Or let's put it the other way around. Even if you are producing small amount of aldosterone, your thing will be done.
Yes.
So that is why we need a much more enzymatic activity to be eucortisolemic as compared to aldosteronemic. So in the sense, that's why individuals, you will think of conditions which we say about salt wasting forms of CH, in which less than 1% of enzyme activity is there, or simple well lysing or classical form in which you have 1 to 5% activity, you will produce enough aldosterone to take care of it. So that's why aldosterone deficiency becomes less likely. That is why quote unquote isolated glucocorticoid deficiency occurs in a number of conditions in which you don't really have true sense isolated glucocorticoid deficiency. What is the real cause of isolated glucocorticoid deficiency in your terms?
It's like, ACTH resistant.
So the classical example will be familial glucocorticoid deficiency in which your ACTH axis is gone, but your renin-angiotensin is working. But there are many other milder forms of global steroidogenic defects which will actually present like this. So non-classical form of star can present like similar scenario. You can have many other effects, the steroxin reductase deficiency, they all present with milder form will present only with a glucocorticoid deficiency, because you need 0.1 milligram of mineralocorticoid, while you would be needing around 10 to 15 milligrams of hydrocortisone to ensure that you have got a good outcome in that perspective. So this is something you need to be careful about. Now, usually the cortisol endogenous production is 6 to 8 milligram per meter square per day, but because of absorption issues, we tend to use 10 to 12 milligram per meter square per day. And this gives you a guide about how much dose you should replace. So if you compare, Dr. Sandeep, you have got a person who has got a central cortisol deficiency, a secondary or tertiary form, you've got a primary adrenal insufficiency, and you've got a child with congenital adrenal hyperplasia. What is the approximate dose, first of all, in terms of order of hydrocortisone dose, and then what dose would you recommend in that scenario? Hmm.
10 to 12, sir.
Yeah.
10 to 8 to 10, sir.
Mhm.
And CH we do 12 to 15, sir.
So maybe we can think of 10, 12 and 15 as the ideal one. So central one require much lower because there is some ACTH independent production of cortisol. What really ACTH does to cortisol production?
It acts on the adrenals to produce cortisol and.
No. That is a very generic thing. What I'm thinking, what is the specific role of ACTH? What does it? Yeah. So how does it stimulate the production? What is the primary mechanism?
The receptor.
Okay. So I'm asking, what does the receptor do? It largely acts on the star. The primary mediator of ACTH is the steroidogenic acute reactionary protein, which increases the rate of transfer of cholesterol. It also increases the LDL activity, it also increases the HDL activity, increases the adrenal size. So many things are there. But the primary role, if you ask me, is basically the star activity. So it is going to increase. So your factory is going to produce more, but it's not that if you don't have any ACTH, some baseline production will already be there. So that is why when you have a primary adrenal problem, your adrenal is gone. So it won't produce anything. But if you have a problem in the pituitary, your ACTH is not coming. There is some ACTH independent production. Similarly, you have a TSH independent thyroid production, which is also there. So individuals who have central hypothyroidism or central hypoadrenalism will require a lower dose of thyroxine, a lower dose of hydrocortisone as compared to a primary problem. This is important. So you said 10, 12, and in CAH you need higher dose because you want to suppress that. And this comes from the biochemical synthesis rate. Aldosterone is only 0.1 milligram per day. So if you are producing that much, you are happy. You don't need a very high dose in that regards. And DHEAS is 15 to 20 milligram per day. What is the biological role of DHEAS besides the hair production, besides the acne and all those things that you have? In predominantly, I'm talking about from a normal male and a normal female. What does DHEAS do? If it does something. So that I've already said.
Steroid hormones are also produced from DHEAS.
That is different. Then it is an intermediary. So what I'm saying, what is the absolute effect? Does the DHEAS have a role, or if you don't have a DHEAS, would that be a problem at all? So DHEAS has been associated with quality of life, also associated with libido in the setting of females in particular. So people talk about giving DHEAS to individuals, particularly women who have primary adrenal insufficiency, or even central also, they are not going to produce DHEAS to improve their quality of life. So this is the role of DHEAS, which is emerging from that perspective. So it's not that DHEAS is only a mild form of androgen, it also has some other role from that perspective. Now we know that ACTH, so we talked about the corticotropin releasing factor, which is going to regulate ACTH. The ACTH, like many other peptides, is produced from a large precursor gene, which is the pro-opiomelanocortin. And the name itself is very, very clear. It tells you what it's going to produce. So you've got the POMC, which has got the signal peptide, then you have got the N-terminal, and then you've got three major areas which are going to produce. You've got the melanocyte stimulating hormone MSH, then an intermediary intron area, then you have got the ACTH area, and then you have got the LPH area, which is responsible for endorphin production. Now, if you go one by one, MSH, we already discussed, is going to act via the MC4 receptor to have a role on the POMC, MSH, MC4 receptor, which is basically an anorexic pathway. It is going to tell you that, okay, you have had enough, now stop eating. So it's going to work on appetite. And of course, it's a melanocyte stimulating hormone, so it's also going to work on in terms of your skin pigmentation and hair pigmentation. The ACTH is going to work on a similar receptor, which is the MC2 receptor, to cause production predominantly of cortisol. There are many other effects of ACTH which we are not going to work. Mainly, we are focusing on the effect as far as the cortisol production. And endorphin, we know, works on the endorphin receptor to reduce the pain. So if somebody is in a stressed situation, what is going to happen? In stress, we know that you produce more ACTH. You're producing more cortisol, but what else is happening here? So you'll have more endorphins. So if you are in a frightful situation, if you are wounded in a battle, if you have a sort of a tiger in front of you, you want to run. So you want to forget your pain. So that is why this endorphin is being linked in that perspective. You want to eat more so that you can basically compensate for the energy requirement which is there. These things can happen. So these happens together. The other way to look at it, if somebody is, let's say, sleeping late at night, what happens with the cortisol rhythm? So normally cortisol should be lowest at highest in the morning. So lowest at midnight. But if suppose you are waking up at that time, your light is on, so in that scenario, your cortisol is high. What else would be high along with cortisol? MSH. You will want to eat more. So that's why often if you see somebody is reading late at night, they become very hungry. One, because the brain is using all the energy, but this MSH is already there. So this cortisol excess is going to be associated with increased hunger and going to trigger your obesity, which is something which is important from that perspective. So now just to go forward in terms of clinical correlation, we have a 3-year-old boy who presented with seizures. Blood sugar was 24 and it was a ketotic hypoglycemia. There was also a hyponatremia. So often we say, okay, ketotic hypoglycemia do not work up. But this child has hyponatremia. So what is the clue you are getting out here from? So you have to definitely look at cortisol deficiency. Is it an isolated cortisol deficiency in your opinion, or is it the combined glucomineralocorticoid defect? So it is unlikely to be mineralocorticoid because your potassium is low. That is very unusual. Cortisol is low and ACTH is high. So what are you thinking of now?
Cortisol, hyponatremia and low blood sugar level. Cortisol deficiency is causing this low blood sugar and ketotic hypoglycemia. And ACTH is high.
So what is the cause? So what do you mean by isolated cortisol deficiency? Most likely cause will be ACTH resistance. You've got high ACTH, low cortisol, and you've got a normal mineralocorticoid. So your primary diagnosis will be ACTH resistance. Now, other things could be there, but that you have to think of in that regards. So it was labeled as Addison's, which you would agree or not agree.
The access will also be.
There may be some time course that in the initial phase you don't have that much destruction, but if you have this high ACTH, somebody is having hypoglycemia, I don't expect them to have a normal potassium level. So this is most likely a ACTH resistance. And we discuss, when we talk about adrenals, we'll say there are two major forms. We have got the MC2 receptor problem, or you have got the receptor associated protein problem, which is going to push the receptor up there in that regards. 12-year-old girl with obesity, she is on the shorter side, definitely. The blood pressure seems to be okay. The overnight suppression is not getting suppressed. It's 120. She has pigmentation. What do you think would be the possible cause?
Exogenous.
So this is a sort of a scenario. You're dealing with obesity and short stature. So obesity and short stature, you'd think of Cushing syndrome. Then somebody did a ONDST, which basically means that you have got a non-suppressed ONDST, which is suggestive of a Cushing syndrome, and you have got pigmentation. So it's very simple. It's asking you, what is the cause of Cushing syndrome? Can it be exogenous? You said exogenous. So pigmentation is giving you a clear-cut clue. So it's a ACTH dependent Cushing's disease. So this is what you're looking at. So basically this is a ACTH excess. So you don't have to worry about adrenals. Look at the pituitary.